So, good evening. Dr. Penny, can you hear me? Can someone confirm if I'm audible?
Hi, Doc, you're very audible.
Thank you, Dr. Botella. So, I think it's time we started. And maybe I'll take this opportunity to ask you, Dr. Botella, to pray for us. Kindly.
Tuombe. Father, in the mighty name of Jesus, we come before your presence this evening. We want to thank you for the gift of life. Thank you for the care and protection that you have given unto us. Thank you for the way you've taken good care of us as we were serving your children. We pray that, God, you may continually bless us, even as we are going to have this meeting. We pray that, God, you may enable us to understand what is expected of us. For it is in Jesus' name we do pray and believe. Amen.
Amen.
Amen. Thank you, Dr. Botella. So my name is Dr. Emmanuel Mula. On behalf of Nairobi branch KMPDU, I welcome you to this session, which I hope will be very informative to all of us. At this juncture, I would like us to directly move to the presentation, but before the presentation, I would like to welcome Dr. Mwange, who will then welcome the NHIF team to make a presentation. Karibu, Dr. Mwange.
Thank you, Dr. Mula. I hope I'm audible. Good
Very
evening.
audible, Doc.
Thank you. Good evening, everyone. I would like to invite you all to this much needed meeting. I'm glad that we are quite a number, more are still joining in. So if you can, please tell your colleague to join in, because this is information that is very important to all of us. This meeting has been occasioned by the numerous queries that have been coming to myself and Dr. Dede, who are directly involved with this scheme. And I don't think I want to take too much time. I would like to invite the NHIF team, maybe led, I can see Ann Kibor, Judy Otele, Erastus Makali. Maybe Ann, you could take over and invite your team, introduce your team, and we can take it from there.
All right. Good evening, everyone.
Good evening.
Sorry, my name is Ann Kibor. I work in the Enhanced Schemes section in NHIF. We sit in the same committee with Dr. Mwange and my colleagues who are here administering the civil servant scheme. So I believe the agenda of the day is to be able to do a presentation on the scheme, on the provisions of the scheme and access rules. But before we get to that, allow me to invite my colleagues to also introduce themselves.
Good evening. Can you hear me?
Yes, we can.
Yeah, my name is Makali Rastas. I work at NHIF at Enhanced Schemes Division together with Anne. We also sit in the same committee that is in charge of implementing the scheme. Thank you.
Otele? Otele was also. Okay, I think Otele is also in the meeting. Otele, please introduce yourself. Okay, maybe Otele can introduce herself later, but she's Judith Otele, the manager case management in NHIF. She's also in the same committee that administers the scheme. on behalf of the members. Dr. Penny?
Thank you for that. Dr. Dede, would you like to say something before I hand it over to the NHIF team to take us through the presentation?
Thanks, Penny. Good evening, everyone. I'm Dr. Esther Dede. As Penny said, yeah, we work together and we've been getting quite a lot of questions about the scheme, and I'm happy that we have occasion to have this meeting today that will iron out some of those gray areas that we have. Thank you.
Great. Now, other than the doctors and the NHIF team, we thought it was important to have the HR team represented here because they also get a lot of queries, and especially when it comes to excess of loss. I have seen Lilian Shikanda here. Maybe just say hello, then we can get on with the presentation.
Good evening, everyone. My name is Lilian Shikanda, Human Resource Officer for NMS. I'm happy to be here. Thank you.
Okay, over to you, Anne and the team. I don't know who is doing the presentation.
I need to be enabled to share.
Dr. Mula, could you enable Anne to share?
It should be okay now, Anne.
All right, can you see my screen?
No.
Not yet.
Now you can see it?
Yes, we can. Thank you.
All right. We should use in a better format than that. Is it clearer? I hope so. All right, so allow me to take you through the presentation, then we can have comments from the team, from my colleagues, as we move forward. So we are doing a sensitization on the comprehensive medical insurance scheme for civil servants. We renewed the contract recently on 1st of July, but there were a few changes which we will highlight, but essentially the benefit package is the same. There are a few revisions in terms of access guidelines, especially when it comes to some of the healthcare providers, but we'll discuss that as we move forward. Now, I think for the first time last year, we had NMS co-opted into this contract. The NHIF was contracted to administer the scheme, and the beneficiaries of the scheme include civil servants who work at the national government. We also have staff seconded to county governments and staff working under Nairobi Metropolitan Services. So those are the beneficiaries of the scheme in terms of the principal members. The cover, besides the principal member, who is the employee of any of the three government bodies or arms we're talking about, we also have the declared spouse. So the principal member is the employee of the NMS in this case. Then we have a declared spouse, one declared spouse. Under the eligible beneficiaries, you also have declared children up to 5 children. Now, if you have 5 children, it means they're automatically covered under the premium paid by the employer. If you have more than 5 who will call additional children, you pay for them as the principal member being the employee. Now, the children are covered up to the age of 21. If they're above 21 years, we cover up to a maximum of 25, if wholly dependent on the principal member and enrolled in full-time post-secondary education. You will find that when, yes?
I'm sorry to interject. I don't know whether is it my side or I don't, the PPT is not running. It's just
Yeah,
stuck on
the
the
slides are not moving.
slides are not running.
Oh, okay. On my side, it seems to be moving, so let me see. Let me reshare again and see if it's going to be different. Okay. It appears there's a challenge on my side. Okay, just a moment. I don't know whether we can all view the eligible beneficiaries screen.
Yeah.
Yes.
Try to move back.
Yes, we
Now
can.
clear.
Hi, Zuri. Hi, Nathan. Zuri, you didn't say hi.
Yeah. Okay.
Hi, Zuri.
I think it's working now.
Now, all right. So so we are at the slide on eligible beneficiaries. So let me just recap that. So the principal member is an NMS employee in this case. Then you have one declared spouse covered. Then declared children up to the age of 5 are automatically covered under the premium paid by the employer. But if you have above 5 children, who we are calling additional children in this case, then it means as a principal member, you'll need to pay an additional premium for them, which we will see how much you pay according to the job group which you're in. Now, the children are covered from age 0 to 21 of age, and declaring means you just bring a birth certificate. But if your child is above 21 years, up to a maximum of 25 years, they'll be covered if they're wholly dependent on you as a principal member and enrolled in full-time post-secondary education. Now, a child with disability who is wholly dependent on the principal member, in this case, shall not have an age limit for coverage. It means that if I have a child who is above 25 or above 21, and they're registered under the National Council for Persons with Disability, then they are covered by the principal member or by my cover if I'm a principal member for the lifetime of the cover. The age limit does not apply in this case. Now, for a declared spouse and dependents, in case a principal member dies, then the declared spouse and dependent continue accessing services until the end of the contract period, subject to a payment of statutory contributions of 500 shillings for the remaining months of the contract. What this clause means is that in case an NMS staff dies and the cover is on, and they have declared a spouse and children in the cover, then the spouse and children continue enjoying the cover until the contract period ends. Like, for example, the contract now is 1st July 2022, ending on 30th of June 2023. However, there's paying the 500 shillings every month, which would have been the statutory deductions if the principal member was, if they were employed and they were alive. Because as employees of NMS, you're deducted every month as per the statutory contributions that you're required to pay as NHIF members. Now, in case a principal member retires, for principal members who retire within the contract period, they'll continue to access. I think somebody needs to mute their mic, or the host can mute. All right, so if a principal member retires, I'm an employee of NMS and I retire. All right, so if a principal member retires within the contract period, they'll continue to access benefits until the end of the contract, subject to payment of statutory contributions of 500 shillings per month. So it's a similar clause to the one we discussed earlier, but as a principal member, you'll need to continue paying the 500 shillings, which is the contribution paid for the retirees or a certain category of statutory contributors. I hope that's clear for us. Somebody else needs to mute their mic. Now, we spoke about if you have above 5 children, what do you do? As a principal member who is an employee of NMS, you're required to pay additional premium for that specific dependent. And as you can see from the slide, it's graduated as per job group. So if you're in job group A to G and you have only one additional child, you pay 3,500. That's A to L. If you have 2 children and above, so there is no limit for the above 2, you pay 6,000 shillings. So if I have 2 additional children, I pay 6,000. If I have 5 additional children, I'll still pay 6,000. And it's graduated as shown. Now, it's important for us to know that if I have an additional child, if I pay a premium of maybe 3,500, it expires with the contract end date of the contract. Because then we have some members who want to come and pay, let's say in January for a cover that started in July, and they expect that that money will go for the full year. That's not the way it works. If I have an additional child and I pay additional premium, it means when the contract is renewed by the employer on the 1st of July or the next contracting period, I'll need to pay another additional premium for that child to be covered. Now, how do we register with NHIF? I think most of us are members. So the members of the scheme must be duly registered to be able to access services. How do you register? The manual of registration, which is the traditional way, has been to fill a form at a branch or the Huduma Center. NHIF has a desk in every Huduma Center in the country. The required documents are a copy of the ID for the member, the principal member, and or a spouse. So if you have a spouse, you'll need a copy of the ID of your spouse. A marriage certificate or affidavit from an advocate is also required to declare a spouse. Then if you have children, you need a copy of the birth certificate for children who are above 6 months. So if a child is 6 months and below, you are allowed to declare with a birth notification. However, you'll be required to bring a birth certificate once that child is above 6 months, because in our system, the unique identifier or the number that we put to identify a child is the birth certificate entry number. So the notification is allowed for a short-term declaration for a child who is below 6 months. Now, for the children who are disabled and are dependent on the principal member, then you're required to provide a certificate from the National Council of Persons with Disability to NHIF for that child to be allowed to access beyond the age of 21 or 25. Now, for all for yourself and your declared dependents, we require a passport photo. Now, NHIF has gone digital. We have what we call self-care platforms. So as a digital member, you can also use the NHIF self-care platforms to register yourself. You can actually use the USSD code *155#, which works on a smartphone or a non-smartphone. You can also register online through the NHIF website. So if you go to the NHIF website, you can actually register yourself. You'll be issued with an NHIF member number. For those of us who have smartphones, you can download the mobile app from your either Apple Store or your Play Store. It's called My NHIF. You can register through that. You can also check your status in terms of the payment using your NHIF app or the *155#. Yes.
Please.
Is somebody asking a question? Or can I proceed? Okay.
Proceed.
So for all right. So members shall undertake biometric registration at the NHIF service point. How many of us are, but if you visited a hospital lately, I think the hospital has been asking you to use your fingerprints for verification, for discharge, and to access services. So from last year, NHIF embarked on biometric registration for all the members and the the dependents. So for those of us who are registered or who are not registered, visit the nearest NHIF service point for registration. And if your family is not registered, if you have a child who is 7 years and above, their biometrics are taken. If they're below 7 years, we will use the one-time PIN when they need to access services. And that one-time PIN is sent to the phone number of the principal member, which you're required to actually make sure that it's in the NHIF, your NHIF record. Now, let's discuss change of declared spouse. This has been an interesting issue because we have situations where you may need to change your spouse for one reason or another. Now, where a member changes their declared spouse for the first time, in a waiting period of 30 days from the date of the change apply before the spouse is eligible to access services. Now, this is important because we have members who want to change a spouse when they're already admitted in hospital. That spouse will not be able to access services. So it's important that if you have a change in spouse, kindly come and declare the change as soon as possible so that the 30-day waiting period can expire before they need to use services. Now, for any subsequent change, if I've already changed my spouse once during that contract period and I need to change again to another spouse, then a waiting period of 6 months applies from the date you change. So that new spouse who's been changed for the second time during that contract year cannot access for the next 6 months. However, there's an exception to this rule, because then if the change is due to the demise of a spouse, in the unfortunate situation where a member loses a spouse, if you provide a death certificate, then we do not impose a waiting period. So the new spouse who you declare following the death of a spouse will actually be able to access services immediately. All right. Now, we've had one of the queries which we keep having is that I have a child who's not declared, the child is already admitted in hospital. What do we do? We are encouraging our members to kindly declare your dependents at the earliest opportunity possible. When a child is, for example, if someone delivers a child and that child requires healthcare services, we are able to declare that child immediately when they're in hospital. But this may not, we can also assist for a child who's in hospital, but that's not the most ideal situation. If all of us as members declare our existing dependents, then it means even access to services in hospital is easier and quicker. Now, let's talk about access to services briefly. How do we access services? We have, under the cover, we have outpatient services, we have inpatient services. We also have dental and optical, and I know those ones fall under out or inpatient. But the reason why we explain like that is because there are limits for outpatient, inpatient, maternity, dental, and optical, which you will see as we proceed with the presentation. Now for outpatient services, I think for NMS, since you joined this year, you joined when you are all on limits. For those of you, the other members who are there initially, we had some job groups that were on capitation. But for NMS, I know you joined when all the members were on limits. Now, we access on fee for service. Fee for service simply means if I visit Nairobi outpatient services and I spend 5,000, that's what is deducted from my limit. And the lowest limit for this cover is 70,000 for outpatient. And that limit is on a family shared basis. Now, what are the requirements of the healthcare providers? We are in Nairobi, so the healthcare providers use biometrics. We are still, we'll ask you for a copy of the NHIF card and a copy of the national identification card. But the process of using only biometrics we are still transitioning to that. So it's important that we all have our biometrics done, because I know in a city like Nairobi, you will be asked for your biometrics to be able to access outpatient. Now, the issue of exhaustion of limits will come in this discussion, because then if I have a limit of 70,000, how I manage my limits is important, because then if my limits are exhausted, it becomes another long process to be able to access. All right. So how to access inpatient services? I require admission in a facility. So all beneficiaries shall access inpatient services on fee for service, because you also have limits for inpatient. The lowest being 700,000 for job group A to G. So we have all beneficiaries shall access inpatient services on fee for service within their limits, which are on family shared basis. Now, the documents required at the point of service, you will still need to use your biometrics. We are also asking for a copy of the NHIF card and principal member's ID, who is the employee, a copy of the spouse's ID if the spouse is the one who is admitted, a copy of the birth certificate for a child who is above 6 months, or notification for the one below 6 months. For a child who is being declared and is adopted, we will require a copy of the adoption certificate. These are rare cases, but they actually happen. Then for the child who is covered under the disability clause, a copy of the certificate of registration with the National Council for Persons with Disability is required. Then a letter of proof that the child is enrolled in a full-time learning institution for children who are above 21 years will be required. Now that's for inpatient services. Now let's look at how much our limits are. Sorry, I think my slide moved slightly. Okay, so for, am I moving my slide? All right, so for the limits for this financial year, for last financial year, which are the same as for this financial year, because there were no increase in limits. From job group A to G for inpatient, for inpatient, the limit is 700,000 from A to K actually. For outpatient is 70,000. Maternity limits for A to H are 100,000. Optical and dental is the same for all job groups. So optical is 40,000 and dental is 50,000. The other limits for maternity for job group 11, job group I don't know if I'm muted or not. I don't know. Can you hear me?
Yes, we can.
Okay. So 150,000 for job group J to P, then 200,000 for QRST. All right. So we can move on from that. So depending on the job group which you are, you can see the limits for in and outpatient, and this is on family shared basis. So it means that for your entire declared family, these are the limits that you can use when you're in hospital. Now, Dr. Penny, I don't know if we should discuss the issue of excess of loss now or the plenary.
You can actually bring it up now.
Okay. What happens if we exceed our limits? Now we have, the employer has provided a fund, which is called the ex gratia, excess of loss fund. We also call it ex gratia because traditionally in the civil service, it's been called ex gratia. What happens is that if I exhaust my limits as a member or as a family, it means that I can apply from my employer for money to be spent from the excess of loss fund that is managed by NHIF. Now, how this process is done is that a letter needs to be done from your head of human resource to the State Department for Public Service, which is the one that signs the contract on behalf of all the members for consideration. Now, this happens in two ways. I'm being seen for a chronic condition, and it's an outpatient visit, and it's a planned visit. It means that I'm scheduled to see Dr. Penny next week on Thursday. Then what happens in that case is that we request the member to get a tentative bill or a quotation for the service that they need. That quotation is attached to the letter from the human resource for NMS. You have a director HR, Dr. Penny?
Yes, we do.
Yes, so the letter is done by the director HR, because I know for the ministry is the head of human resource who does the letter, to the PS State Department for Public Service, requesting for use of excess of loss funds or ex-gratia funds. Now, the PS State Department for Public Service will then write to the CEO NHIF if they authorize for that money to be used. That is how the member can benefit from the excess of loss funds. However, if it's an admission, it means that for you to apply, that patient has to have been discharged, because then the State Department for Public Service approves for the final bill. It does not give a blanket approval for any excess of loss. Now, one of the guidelines that we have in terms of use of excess of loss is that for patients who are being seen on admission, they need to be admitted in what we call comprehensive facilities, either government or faith-based, but the ones that have signed for comprehensive contracts, for prudent management of the excess of loss fund, which has to be utilized by all the beneficiaries who really need these funds. I hope that is clear for the benefit of the members. I don't know if you are clear about that, or there's something else you'd like to add, Otele or Makali, so that we can, because I know this has been an area where there's a lot of confusion when it comes to utilization of this or the access to benefits for this cover. Otele or Makali?
Nothing for now, Anne. Just proceed.
We can continue.
Anne, maybe I could add something or emphasize something, that the excess of loss is restricted to only chronic and critical conditions. And then there's the process that you have to follow. However, there are many other parameters that are looked at when applying for this excess of loss. And maybe as Anne mentions, the restrictions in terms of the hospitals that members can access services, that is one area that the committee actually looks at to approve the excess of loss. And you can continue.
All right.
Sorry, before you continue, Anne, I have a question. For this, you mentioned that there are comprehensive facilities, which in case you're applying for excess of loss, then you have to be admitted to these facilities. Is there a point where you'll mention which these facilities are?
We'll share the list of facilities, but we can also mention at the end of the presentation, but we'll also share a list of the facilities.
And then another question. I don't know if you also mentioned it or if you took it into consideration. Suppose a member has been admitted for critical illness in a certain facility and they exhaust their cover, they apply for excess of loss, then they have to be transferred to another facility, which, then they have to, whatever facilities they have been admitted in is not in the list of comprehensive facilities, and they have to be, that basically means they have to be transferred to another facility for care. So did you take into consideration or the issue of continuity of care and any other parameters that may be involved when you have to transfer, or is it just automatic that you just have to work out the transfer for this patient? I hope my question is clear.
Yes, it is. So I don't know, Otele, are you in the meeting?
Yes, I'm here, Anne. Good evening.
Good evening.
I'm listening. So if I could answer, am I audible?
Yes.
Yes, you are.
Yeah, if I could answer, we don't insist on transfer of a patient during an admission period. usually the practice has been, if you're admitted, let's say Mpisha or Aga Khan or Nairobi Hospital, for that admission period, usually it is unlikely that you'll be asked to transfer in between admission period. But should that care be required at the end of should you require additional admission or care after you've been discharged, then you'll be admitted to a comprehensive facility. But up to now, mostly we prefer that care continues in the facility to where you are admitted, unless the diagnosis is like disability where you may need rehabilitation, and which is likely to be a long-term admission. That's when we could say you can be transferred like to a rehab, not the drug and substance rehabilitation, like the physical rehabilitation. Then we could transfer to a rehab, physical rehabilitation, where it is more cost effective. But up to now, for an ongoing admission, the ministry has been very kind to ensure that the member completes that admission in the facility, whether it is non-comprehensive or not. So I hope I answered that question that has just been asked. Thank you.
We are
Yes,
clear?
you answered. Thank you.
Okay. Sawa. Can I proceed?
Yes, please do. And maybe we can answer, you can answer questions at the very end.
All right. So provisions of the comprehensive medical insurance scheme. This is about the benefits, what is covered.
Hello, yes,
Somebody else needs to mute. So this is a summary of the benefit package. You have the outpatient and inpatient cover, dental and optical, overseas treatment, radiology services, annual medical checkup, maternity package, drug and substance abuse rehabilitation, chronic illnesses, renal dialysis, evacuation services, and test for organ donors. That's a summary of the benefits that this scheme offers the beneficiaries. We'll look at a little bit more detail of the specific benefit packages. So for the outpatient care cover, the content, this may not be the entire list, but this is what it covers, including this: consultation with a general practitioner and specialists, basic lab investigations, drug and dispensation, health education, wellness and counseling, physiotherapy services, and some vaccines are covered: the KP vaccines, the rotavirus vaccine, anti-rabies, and anti-snake venom vaccines are covered. Now, this may not have the full list, but this is what some of the things that are covered under outpatient cover. The inpatient cover includes the hospital stay with healthcare diagnosis, consultation, accommodation, and bed charges, nursing care, diagnostic lab tests, radiology examinations, physicians, surgeons, anesthetists, physiotherapists fee, operating theater charges, specialist consultations or visits, prescribes medication and dressing. Now, we also have maternity and reproductive health. And as I pointed out before, the maternity package has a limit to how much can be paid for that. So we have under the maternity and antenatal care, delivery, it's normal or CS, and postnatal care, all family planning services, including fertility treatment. Then it covers a principal member and declared spouse only. Now, that's the last point is important because we've had situations where the child of a principal member is requesting for maternity services. That is not covered under this scheme. It can only cover the principal member if they are female or the spouse of a principal member. Now, we also have renal dialysis. And renal dialysis, it caters for hemodialysis for the needed care plan, including specialist reviews, nursing and dialysis services, intracare and dispensed medications, routine lab tests, nutrition, counseling, and follow-up. The next package is the rehabilitation package, drug and substance abuse. I think we've christened this now.
Comprehensive cover.
Somebody needs to mute. All right, so the rehabilitation package includes rehabilitation treatment for persons addicted to harmful or hazardous psychoactive substances. I think this package has been renamed and revamped. Otele can give more details later on. We also have the radiology package, including all diagnostic imaging services, the CT scan, MRI. I know we have others included in the radiology package. We also have orthopedic and other appliances for patients who need crutches, prosthetics, hearing aids, pressure stockings, and other appliances. They are covered under this package, this cover. Now, surgical package includes all surgical procedures, including transplants, with an exception of cosmetic surgeries. So we don't cover cosmetic surgeries, but for medical reasons, we cover. Then you also have organ donor testing, which is a unique feature of this scheme. Pre-test cost for kidney donor identification up to a maximum of 2. So for a patient who requires a kidney transplant, then the cover will pay for the pre-tests for potential donors, but for only 2 of the potential donors.
It has organ
I think several people need to mute, or the host can mute. Then we have oncology package, which includes treatment for cancer patients using radiotherapy and chemo. Then dental package. The dental package, remember, has a limit of 50,000 per family per year. Now, under that, we cover the dental consultations, orthodontics, root canal, dentures, cost of filling, x-rays, and extractions, including surgical extractions, together with anesthetics fees, hospital and operating theater costs. Now, optical package also has a limit. I think we saw in the limit table per family per year, and that covers the consultation, cost of consultation with the ophthalmologist or the optometrist, eye testing, and glasses for refractive errors, optical frames, and lenses. Now, it's important to note that for this scheme, the frames have a limit. You can, the cover pays for frames up to 7,500 shillings for the frames. So if you would like to have frames that are more expensive than that, then the cover will cover the cost up to 7,500. It's important that we are, because that's another query we keep having from the members. Now, we also have the local emergency road ambulance service, which currently is the service provider is E+. We popularly know it as Kenya Red Cross. That covers the emergency evacuation, transportation, and transfer of a sick member or dependent for treatment at the nearest NHIF declared hospital. To access this service, there's a toll-free line, which is 1199, which whoever is in the scene can actually call and the member will be evacuated. Under this package, you also have the emergency air rescue service. The emergency road ambulance covers a member or dependent, but the emergency air rescue covers only the principal member. So for that, the transportation and transfer of an injured member to an NHIF contracted facility where adequate care is available within the territorial limits of Kenya. So if you require emergency air rescue services, then the service provider currently is Amref Flying Doctors, and the doctor or whoever is handling the patient can call any of these numbers for that evacuation to be done. But it's important to note that it covers only the principal member who is the employee of the NMS. Under this package, the benefit package, you also have foreign treatment. Now, foreign treatment covers for treatment costs arising from a condition that warrants treatment that is not available in Kenya, which means that the specialist has referred this patient for treatment outside the country. Now, the cover includes treatment costs for a patient or organ donors where applicable, the cost of travel and accommodation for the patient and one person accompanying the patient, then cost of travel and accommodation for the medical personnel accompanying a patient. Now, for situations where a patient may require to be accompanied by the medical personnel, doctors, the doctors, or a nurse, then they are covered for a period not exceeding 2 days. Now, reimbursement for claims emergency treatment incurred while the principal member is temporarily outside the country on official duty if the period is not exceeding 6 months at any one visit. Now, what this means is under foreign treatment, you may be outside the country for work, or you've gone for a seminar or whatever reason you're outside the country. Then this scheme covers you, but this is actually done through travel insurance. So if you're required to, if you're traveling outside the country on official, then you need to bring a letter to NHIF from your employer showing that you're traveling, and the biodata page of the passport, and a request for travel insurance. What we'll do is to process a travel insurance cover for you, which you travel with. Now that travel insurance will cover you in case you require emergency treatment while you are on that assignment outside the country. But this cover, the travel insurance cover, expires in 6 weeks. So if you're outside the country for more than 6 weeks, it means you may need to make other arrangements beyond the 6th week. Now, under specialized treatments, the requirements for specialized services will be on referral basis. There are many times which our members want to refer themselves, or actually do, without any referral from a doctor to a specialist. It's a requirement that you have to be referred for specialized services first for us to cover. Then the healthcare provider is required to seek authorization from NHIF through the NHIF system. So if I've been referred to see Dr. Alan, who is an oncologist, for example, and is in Nairobi Hospital, the Nairobi Hospital will do a request through the NHIF system for me to approve that, for NHIF to approve for that care. Now, specialized services are available in NHIF contracted facilities. I think we'll share the facilities so that we can know where to refer patients, because I know several of us are doctors, or we can know where we can be referred to if you're the patient. Now, specialized services covered, okay, there are many, but then we just put a few in the slide: renal dialysis and renal transplant, optical and dental, chronic illnesses, radiological test, oncology, pressure stockings, drug and substance abuse rehabilitation, among many others classified as specialized treatment. Now, overseas treatment has a process. The process includes a referral letter from the treating doctor. You also require an approval from the Director General from the Ministry of Health, which is, this is a guideline issued by the Ministry of Health. So as NHIF, we are there to that guideline. Now, once you have this documentation, the request comes to NHIF for now the logistics, planning, and travel and accommodation to be planned for the patient. Now, if it's organ donation, kidney transplant, then the potential donor must be a registered NHIF member. That's one of the conditions that is. Now, what does this cover? For the patient who is planned treatment, we cover the travel and accommodation for the patient and one accompanying person. That's the first thing. We also cover the travel and accommodation for the organ donor in case of organ donation. And this also covers the treatment costs. But then let's remember that overseas treatment is covered within your inpatient limits as the principal member. It's covered within your inpatient limits as a principal member. If the treatment exceeds the inpatient limit, it means you need to apply for the excess of loss or ex gratia to cover whatever is above your inpatient limits. And this, by the way, covers the member, the principal member, the spouse, or the children are covered for overseas treatment. And every other benefit except.
However, we have organized in such a way that the letter delivery of the boxes are
somebody needs to mute something. Thank you. Now, as discussed before, overseas issue of travel insurance. And I already pointed out the requirements: a letter from the employer clearance, passport, which is the biodata page of your passport, and the travel dates or air tickets, so that the travel insurance can be processed. Now, the features of the travel insurance: first of all, it's processed in 72 hours. So if I'm planning to travel, it means I need to pay early. Not you come on Tuesday and you expect a travel insurance by tomorrow. No, apply on time because it's processed in 72 hours. Then the cover goes for a maximum of 6 weeks, as pointed out before. Then the package includes medical expenses, medical evacuation expenses, repatriation of mortal remains in case of, and burial expenses in case of a death, and coffin expense and the expense for the accompanying family member. I think this needs to be separated. It also covers personal accident, emergency assistance, or travel delays. Those details will be, if you request for the cover, the policy will have additional details of how much, or how much this benefit is. Now, annual medical checkup. I think I'm talking to mostly doctors. I hope we have all done our annual medical checkup. Every time we do this physically with the sensitization of the members, we have less than 2% who have done the annual medical checkup. So Dr. Penny and her colleagues, I hope as doctors, you're leading by example. So for the annual medical checkup, it covers the principal member and spouse. You're eligible for once in a year and general medical checkup at the NHIF contracted healthcare providers. We'll share the list. Now the checkup includes the following tests: BMI and nutritional advice, okay, which is essentially not a test, but anyway. Then you have blood pressure, we have kidney function test, prostate specific antigen, breast ultrasound and mammogram, random or fasting blood sugar testing, liver function test, and pap smear. Dr. Penny, I think something changed, or tele, in this cover this year.
Yes, there were other tests that were added. ECG, prostate ultrasound, lipid profile, liver function. Oh, I can see liver function. Okay, yeah. Chest X-ray.
So in part of the discussions for negotiation, those were the tests that were added as they were seen as essential to make the annual medical checkup useful or helpful for the patients or for the members. Now, I think my slide is frozen. Now we have a few exclusions to this cover. What will not be paid: treatment arising from non-accredited health facilities or unauthorized referrals. So NHIF has a large number, I think almost every healthcare facility is accredited by NHIF. But if in the case where a patient visits an unaccredited facility and it was not an emergency, then it will not be covered under this scheme. Cosmetic surgery or beauty treatments or cosmetic procedures, including complications arising from these procedures, will not be covered. Massage will not be covered. If a patient requires massage or physio as part of their treatment, then it's covered. Then you have treatment by chiropractors, acupuncturists, and herbalists are not covered. Self-prescribed procedures are also not covered. Medical costs related to or incurred in research environment and clinical trials are not covered. Then we have the treatments not covered under the contract stay overseas for more than 6 weeks, which is essentially the travel insurance that expires after 6 weeks. Then laser eye surgery for correction of refractive errors is also not covered. Now, I think we're almost at the end. So these are some of the access rules that we need to be aware of as members and as also those of us who guide members. And I know for most of you, they'll ask you questions because they expect you to know. So number one, members access services are the designated healthcare providers. We have as one of the things that has changed in the contract this year is that we have some healthcare providers at job group A to K can only access on referral, and we'll share the list. So as a first point of care, they are not supposed to access those facilities. If they do, then it means the cover will not pay for that visit. But if they are referred or if it's an emergency, then the cover will pay for the visit. We'll share the list of facilities that we are calling it the exception list. Now, access to services outside the designated facilities will be on referral and will be pre-authorized by NHIF, and the pre-authorization is done through the system. So if I've been referred to, for example, Aga Khan for a specific service, then Aga Khan will need to request NHIF for that approval to be done before they treat the patient or for them to treat the patient. Then medical treatment will be undertaken by medical practitioners employed or contracted by the healthcare providers. NHIF is not liable for payment for a private doctor engaged by the beneficiary. So we do have cases where patients say, it's Dr. Penny only who can treat me or else I will not be fine. If Dr. Penny is not listed under the doctors in that specific facility, which means she's treating you as a private doctor, then the cover will not pay for her fee. Then we have lodging fee is not covered post-delivery. Then members will be admitted in their designated rooms in the healthcare providers. Now, as you're aware, healthcare providers and healthcare facilities have all kinds of rooms. In the cover, there are designated rooms for specific job groups. So for A to G, there are ward beds. RST, I know we are allowed standard private rooms, but then it means that if I'm in A to G and I want a standard private room, you pay for the difference of the cost, because then under your cover, you're allowed to be admitted in a ward bed. Now, we also have a list of facilities that require pre-authorization, which means NHIF, Madam Otele's team has to approve and is requested by the hospital. This includes delivery, that's done on discharge, dialysis, because it's planned treatment, the hospital can request for the next, the cycles at the next dialysis for a month, and we're able to approve. For rehabilitation, since it takes a while, it's done on discharge. Optical is pre-authorized, and dental, meaning that these are mostly planned. Optical, I need a pair of glasses, and they request, NHIF is able to approve. For dental, it's also pre-authorized, so the request is done in the system and it's approved within a certain timeline, and Otele will expound a bit more. For MRIs and CT scans, they're also pre-authorized. We also have chemotherapy, radiotherapy, kidney transplant, which are planned treatments. Then for the orthopedic appliances we discussed before, wheelchairs, walking frames, crutches, these are also pre-authorized, because most of the time we'll ask for quotations from various facilities so that we make sure that the patient gets the best appliance at the fairest cost. We also have a PET scan, and for annual medical checkup, the hospital also needs to request for the annual medical checkup as a package, and it is pre-authorized by NHIF for the member or the spouse to access. Now, where can we access the benefits? We have public healthcare providers, you have faith-based healthcare providers, you have private healthcare providers. Now, we will also share the list. Starting 1st of July this year, the facilities in NHIF has been categorized as comprehensive or non-comprehensive, and we'll be able to see that comprehensive can be government facilities, can be faith-based, and can be private, depending on the contract that the facility has elected. The non-comprehensive also are mainly private, and I don't know if there are any faith-based, but they're mainly private facilities, and mainly the high-cost facilities are non-comprehensive. Now, for our members, you can contact us. We have a 24-hour customer care center where you can call through the toll-free line, which is 0800 72601. Then you can also email the Enhanced Schemes Division at NHIF. And we are also present in the social media as NHIF, on Facebook, on Twitter, and through our website and LinkedIn. Thank you very much. I'll end the presentation there and hand it over to Dr. Penny. Thank you.
Thank you so much, Anne, for such a detailed presentation. Now I think we can go to the question and answer session. I can see Makali has been answering a few questions that have been raised on the chat. Maybe I could, what I'll do, I'll just read out some of the questions, and then anyone in the NHIF team can answer. So the first question is, currently, can you use biometrics only? Anne, Otele, Makali, can you use biometrics only?
Okay, on the same, I had answered it on the chat, but I can still answer. Currently, we are accessing in several ways, and one of the ways that a member can access is through biometrics. Then secondly, a member can access using what we call the one-time password, whereby a PIN is sent to your mobile phone that will enable you to, once you present it to the service point, it will enable you to access. So you can also use the one-time password.
Okay. Thank you for that. The next question was, does the outpatient cover for baby-friendly vaccines?
No, we don't cover for baby-friendly vaccine. We cover for KP vaccines plus what and the rabies, the rotavirus, and the anti-rabies, the rotavirus, and the yellow fever, but we don't cover for baby-friendly vaccines.
Thank you, Otele. The next question was on the list of comprehensive hospitals. Could you kindly share a list of those hospitals? I think you mentioned you will be able to do that.
That will be shared, including dental, optical, imaging, and comprehensive and non-comprehensive. That will be shared. Thank you.
Okay. The next question was, for excess of loss, clarify for inpatient. If you're in between admissions and your cover lapses, does it apply? I think, Otele, you answered this question when a member brought it up.
Yes, I did.
Okay. The next question was on why can't, no, Makali answered that. Could you kindly share the inpatient and outpatient limits for imaging and surgeries?
The contracts that we share with the hospitals have those limits. I don't think it will be practical to share with every beneficiary what those limits are, because the only thing that we have really captured very well in the contract with the employer is the maternity. But for surgical and inpatient, where we have the inpatient, it includes surgical, medical inpatient, it includes all those other services. I would also want to clarify MRI and CT scan actually accrue to the inpatient. So if you have a 700 limit, it would then mean for all your surgical, inpatient medical imaging, specialized labs, and all those like specialized, the crutches that Anne spoke about will accrue to the inpatient cover. So, but we are not able to share per surgery because we have more than 600 surgeries, and each one of them has been costed differently. But what we do is in the contract we share or we sign with the hospitals, we have given them a listing and a cost of every surgery. Thank you.
Thank you, Otele. The next question, I'll combine questions on the same issue. It's on dental. Why is it sometimes NHIF declines to pre-authorize for a procedure, e.g. dental, yet one has not exceeded their limits? Sometimes they decline and ask the patient to seek for treatment in the nearest public hospital. Tied to that is someone was asking, NHIF does not cover a large percentage of dental services, such as scaling. Why is it so?
Dr. Penny, you know, we discussed this. The limit for dental, despite your job group is 50 on a shared family basis. But one of the issues that we've been having is the abuse of the package, not by the group we are speaking with, but basically because it's a package that applies to all enhanced schemes. And because we don't want to treat one scheme in a preferential manner than the other, there are those services that we know are prone to overproduction and abuse, quotes in quotes. And so, and you understand, we discussed, and you are there in the discussion, that there are some services which are only allowed to happen in government facilities because mostly they are going to be expensive and they are going to be phased treatment. So we can explain that as a control measure. That's why we sometimes request that the member seeks for service in government facilities, because government has no motivation for engaging in overproduction of services. Thank you.
Yeah, thank you, Otele, again. As she said, we discussed this quite extensively in the last negotiations. And because of the limit of the dental cover, we all know that dental procedures are very expensive. So they really need to do due diligence, first of all, because of the fraud that has been going on. But more than that, that cover, since it's on family shared basis, 50,000 would only make sense in a public facility. And that's why, and the limits were not extended. So I concur with that. The next question was...
Dr. Penny, before you go, the other thing we need to understand is that for dental surgical services, that include like full mouth restoration, that include surgical disimpaction, are covered within the inpatient limit as surgical procedures. So the dental is what we cover under this package, but for other like a surgical intervention, full mouth restorations are provided for within the inpatient cover. Thank you.
Thank you for that clarification. The next one was on maternity cover, and several things have come up on that. I'll combine the questions. Definition of maternity cover according to NHIF. What is the definition of maternity cover according to NHIF? And tied to that is if the maternity charges surpass 150K, why can't one use their inpatient cover? And the third one tied to that is how do you come up or decide the maternity limits without stakeholders' input? Can they be revised?
Thank you, Dr. Penny. I think I'll start with the last one. This is a negotiated contract between the Ministry of State for Public Service and the NHIF. So NHIF does not decide. This is a negotiated contract with the Ministry of State. And Dr. Mwange, you understand the rigorous, it takes almost a week to negotiate this contract. So NHIF did not come up with those limits without the input of the purchaser or of the employer. They were fully involved. And again, in determining this, we also look at the market practices by other insurances. And I think NHIF and the Ministry of State negotiated a good cover for the civil servants. So it is not an NHIF determined limit, it is a negotiated limit. And yes, if your cover is 150 and the bill goes beyond that, you will have to top up. What we've done is we've negotiated with most hospitals, and most hospitals actually contain the costs within the limits that NHIF has. And these are not government hospitals, these are good hospitals, Coptic, Nairobi West, Nairobi Women's, Metropolitan, Ruai Family, Komarok, Bristol Park. There are so many hospitals that are working within the package. So it is just good for a member, because pregnancy takes 9 months for, okay, the baby could come earlier, but it is 9 months. It's good to shop around, members to shop around where they can have delivery within the package that is allowed to them, because the hospitals are available for that. And they are not public hospitals, these are faith-based and private hospitals where a member can have quality maternity services. In defining what the maternity package entails, it entails admission for delivery by a skilled birth attendant. This would be either midwife, or it could range from midwife to an obstetrician. And it also covers the cost of bed, the cost of surgery, the cost of receiving the baby, and the cost of course, professional fee. So that is what is defined in maternity package up to the point of discharge. Of course, postnatal follow-up care is under the outpatient cover. It is important to note the 150 is not like a separate cover from, it is within your inpatient limit. So it draws from the inpatient limit, because I saw somebody asking whether once you exhaust the 150, whether you can still draw from the inpatient limit. And no, the patient, the 150 is part of that, or the 100 is part of that inpatient limit. However, I would want to note, should you have a baby who requires additional care, either in NICU or in the ward because of some complications, then what needs to happen is that you need to declare that baby independently, and then they are notified as independent patient because of medical reason. Again, should a member of the scheme have like preeclampsia or postpartum medical issues, then the benefit package expands to be able to cover the medical issues. So what we are needing here is actually for just the delivery, from the time you get into the hospital for delivery to the time you leave with the baby. Complications after that, like should you require medical management after that, should you have preeclampsia, should you have postpartum hemorrhage as a result of that, that is catered for separately. And should the baby, the well baby will be covered within the maternity package, but should the baby require medical attention or surgical attention, then that is covered for separately. Thank you.
Okay, thank you for that. The next one was on radiology services. Why are radiology services not fully covered, and one is asked to top up cash? And tied to that was someone was suggesting that NHIF needs to relook into pre-authorization and also limiting imaging package.
Okay, I'll answer.
Yes.
Imaging, the cost of CT scan varies from 5,000 in GOK to 61,000 in some private hospitals. So there is need to regulate that. And then there is, again, the contract specifies which member should access services where. And you know that it is in the contract we are going to share that there are members who are not allowed to go to specific hospitals because of the limits that they have. So should you go to that hospital for image, we won't deny you image, but we shall cover up to our liability. and then you will need to top up. So that is why sometimes members are requested to top up. Again, in terms of imaging, the board also has pronounced itself on the limits of liability and how much you are able to cover, because we are still, though we are lucky to have a cover by our employer, we are still in a resource scarce country. So all those factors are brought together, may limit. But if a member goes to a facility that is comprehensively contracted for imaging, there will be no need to top up. But if you go to an uncomprehensive facility and I'm in job group A to P, and I'm not entitled to be there, NHIF will, because again, the patient has a right to choose where they have to be treated, but NHIF will only cover you to the maximum liability for that service. Thank you.
Okay, thank you for that. There was a question on if frames cost more than 7,500, is one then forced to top up so that they can get their spectacles?
I think Anne was clear on that, and the answer is yes. We've put our liability as 7,500 for frame. So should someone require a frame which is more expensive, a designer frame, NHIF will pay up to the limit of 7,500, and the member will be required to top up should they require a more expensive frame. Yes, thank you.
Another question on optical. Yes.
Just as you're putting the questions together, can we give a chance to, I saw two hands, Dr. Kadivane and Dr. Botella. For
yes,
questions.
I'm coming to them actually.
Okay.
Yeah, shortly.
I just wanted also to say, in terms of optical, there are limits of how often you can change the frame and how much often you can change the lens, and this is an insurance practice. So we allow change of lens within every 12 months, but the frame, we allow you to change the frame every 2 years, unless there is a demonstration that either that frame broke as a result of an accident during working hours, or the lens broke as a result of an accident during working hours. But we have limitation on how often someone can change the lens and how often they can change the frame. Thank you.
Okay, thanks for that. I'll give a chance to, I can see two members who have their hands up. I'll start with Dr. Kadivane. You can unmute.
Yeah. Thank you so much for that comprehensive coverage. My question was on the annual medical checkup, and I saw the number of tests given are quite limited. Do you include the thyroid function tests and also a full hemogram?
Yes, as Anne said in the presentation, with this year's contract, we have added more tests into the tests that are covered. And I think, again, through Dr. Mwange, we can share what the annual medical checkup looks like right now. So,
yeah, I really appreciate that.
Yeah, it was expanded, but it is also capped. Okay. So we shall also be sharing the list of the facilities where members can access it comprehensively without having to top up, because some hospitals will charge as much as 40,000-50,000 for annual medical checkup, but we have facilities we've negotiated with, and you're able to get your annual medical checkup at the negotiated rate.
Okay, thank you so much.
And endoscopy and colonoscopy are covered under the surgical package. And so should you require endoscopy and colonoscopy, those can be pre-authorized through the surgical package, and you can have that done, not necessarily as a part of the annual medical checkup, but also for any other GIT issues. Thank you.
Thank you. Dr. Botella, you can unmute.
Good evening, all. Thank you for this session and for the updates that you've given us. I only have 2 questions and 2 challenges. One, I've heard you say that we need to shop around before we visit the facilities. But then maybe for an example, which Dr. Penina came in to help me. So an investigation was supposed to be done in MPSHA. Then the request was rejected. The child was sent to Gertrude's. It was also rejected, and they were told to go to KU Teaching Referral Hospital. But then when they got there, they were told that they don't even know that investigation. Yet the investigation was supposed to be done for 33,000 in MPSHA and 29 at Gertrude's Hospital. But by the time it was approved, at the end of it all, my dependent ended up spending over 40,000 instead of just the 33,000 that were supposed to be investigated in MPSHA. The other incident is when you say there's that limit of cover, like in terms of the scan. Remember, you advise us to go to places, like an example of a place like German Medical Center. They are, for the MRI, they are cheaper compared to other places. But then you find that the waiting time is too long. Remember, we are civil servants, we are employed, we don't have time to shop for these places. It would be maybe your people, it would be better if they can advise us to go places where they are very sure these investigations are being done, and we're not going to spend a lot of time, because when you ask your employer to give you time to go for this investigation, and then you come back the following day, you're like, oh, it was not done because of the waiting time, then they'll think that you're lying to them. So if maybe you can help us civil servants and approve, maybe increase on the amount that you're going to approve, or before you tell us to go to compare the prices to another facility, it would be better if you do that and tell us place that has that investigation done. And like telling us to go to a facility, a government facility, and they don't even have an idea what kind of investigation that is. That's all I have to say.
Thank you. May I react to that? I think doctors can also help us with that, because you see, like PET scan, we are sure it can only be found in Aga Khan and KUTRH. NM scans, we also know they can only be found in Aga Khan. So doctors also know which tests can only be found where. And it's important for the prescribing doctor to say these tests can only be found in like the way you are saying, either in MPSHA or Gertrude's. In relation to shopping, we never said about shopping for other services. We were very particular, we said for maternity. That's the only thing we said you can shop around when you're expectant, to know where you can have, you can be confined comfortably within your cover without having to incur out-of-pocket expenses. But for, I'm certain like that test must be requested by a specialist. They know where that test can be done. So it would be also important for us to, for the doctor to say, like if they ask for bone scan or NM scans, we know they can only be found in Aga Khan. If somebody asked for radioactive iodine, I know it can only be found like maybe in Texas, in Nairobi Hospital. So for other tests, like which are lab, because we don't work with Lancet yet, or we don't work with Pathcare yet, or other labs, it would be important for the prescribing specialist to say this test can only be found in hospital A or B. That also makes work easier for NHIF, so that you are not sent to go to KU because it's not to be a teaching and research and referral hospital, which is more advanced, and then you are returned back. And we apologize for that experience, but it's also important for doctors, and you are part of that team that prescribes, to be able to articulate where that service can be found. Thank you.
Dr.
Again,
Botella.
for
Sorry.
students,
She's come to you.
thank you for that young one who aspires to be a doctor and a member of the scheme. But imaging, we also have very good imaging centers like Precise, we have Vital Rays, we have Plaza Imaging, we have Sona Imaging. So it's not just German. And they are very close to German, like Plaza is in Vital Ray is in Mayfair building. We have one in Landmark. We have one in the building just next to where City Eye is. So, and they are all comprehensive and they charge well. We have MedHill in Real Plaza. So there are many places to go. Personally, I wouldn't say German, but anyway, but there are many options instead of going like to Nairobi Hospital for MRI, CT scan. Of course, if it is like contrast, MRI, CT scan, those ones we shall consider, because we also don't want you to have it in an outpatient setting in case you reacted to the contrast and you have to be rushed for emergency intervention. But when it is just the normal CT scans or MRI, we appeal to you to allow members to go to the cost-effective but quality units where members can go. And civil servants are allowed to go even in a hospital setting. Like CT scan in Coptic Hospital is 8,000, and they have no problem. In fact, like the CT scan of the head is 7,500. So a member can comfortably go there, have a request done, and it is approved, because the civil servants are not like restricted to only standalone imaging centers. Thank you.
Thank you, Otele, for that. Dr. Botella, I see your hand is up. You're not concluded. You can unmute.
Sorry, let me put it down. I'm trying to put it down.
All right.
Thank you.
Thank you. Okay. Dr. Salim, you can unmute and ask your question.
Yes, thank you very much, Penny and team, for that, for your time and explaining to us about these covers. Mine is just to reiterate or to talk about what most people have been asking about, especially the maternity cover. I know that one of the reasons for this, as has been said, is to limit the usage. But on the same note, we can say even the inpatient cover, people can be misusing the inpatient for one reason or another, and maternity is something that is very vital. Limiting it at 150, I think, does not bode so well with so many people. If it can be revised, it would be good. And one of the reasons for this is we are the same people that are performing, for example, I think this includes CS as well. So we are the same people that are delivering our colleagues. And if the patient is, if the cover is within 150, and we know most of these hospitals, how much they would charge, this would also limit the doctor's fee, or how much as a doctor you could charge that patient that is covered within NHIF. And maybe just to avoid reading the question, my question that I had put in the chat, it was about the imaging service, which I think has been mentioned earlier. Thank you.
I could answer Dr. Salim.
Yes.
Yeah, well, I think the terms of the contract are very clear. Like the person's entitled to private doctors and private doctors fee. And I think Anne was clear in the presentation of people in job group QRST. So all the others are supposed to be managed by hospital consultants or doctors. And again, if we look at the practice, even for Jubilee, for CIC, the maternity is actually capped at 150. So it is the market practice. It is not like NHIF is actually paying below what other insurances would pay. It is the practice. And we hear you, but for this contract period, and you know that Dr. Penny, that is what is there. Maybe in our next negotiation, we could articulate the issues that have been brought up by the group and see whether the employer who is purchasing the cover would be willing to pay more, because it is costed. It is costed, like if we have to pay higher than that, it will mean a higher premium for the employer. In the year that we are getting into, Penny, you know that no enhanced scheme is willing to pay more than what they paid last year. So the premiums, they want to contain the premiums as they were last year, yet inflation is there, and the epidemiological data is showing more of increasing burden of disease. So what we could purchase with 6B probably last year, we cannot even purchase with this. So as we discuss, we also need to know whether the employer and Treasury is willing to actually increase the premium to accommodate the additional benefits that the members or the beneficiaries may want to have. And as I go off, I also hope Anne was clear that we also have limit of the number of children and the age of children that can be covered under the scheme up to the 25th birthday. So after when the member or when a dependent child turns 25, they stop being member of this of the scheme. So Dr. Salim, we hear you, but for this contract period up to June 30th, this is what has been negotiated and signed for. We will see if next negotiation there will be money and government would be willing to commit more for the scheme. If it is not able to, then we will see what will happen then. Thank you.
Thank you, Otele. Now, as we're winding up, there are just a few more questions. One was on, someone asked, patients on follow-up for chronic illnesses being managed by a specialist, do they have to be referred every time they are due for review?
No, you don't have to be referred every time you are going. What we request is for, there will always be continuation history of a discharge summary or something like that, which will show that this is a patient on chronic illness follow-up. So you don't need to have, and of course, if there was a referral at some point, that should suffice to, because if you are diabetic, you are not going to stop being diabetic after 1 year or 2 years or a few months. So if there was an initial referral that demonstrates that you require to be on chronic care management, you don't need a referral every time. Even from our own system, we are able to see this patient has been on follow-up for this condition for a while. So the answer is no. Maybe the initial referral is what we are very keen on. Thank you.
Okay. Then the other question was on healthcare during travel. Healthcare while on travel, is it only accessible if the travel is work related?
I can answer that. You will need Strictly speaking, no, but then you'll need a clearance letter from the employer, because as a public servant, it's a requirement.
Thanks, Anne. Then the last, the last set of questions, still on dental. Someone asks, for those who don't have families, why are the dental services restricted? Say if scaling is the only treatment required, why should I be pushed to a government hospital? Yet I have a dental cover of 50,000.
Thank you. Insurance is a pool. So even in calculating the premiums, we know there are people who are alone in the cover. There are people who are just two. There are people who are three. So insurance is about spreading the risk. So if we were to now look at each individual on their own merit, then the premiums we are going to ask the government to pay will be, astronomical. It will be too much for the government to afford. So that's why we cannot now start in administration of the scheme. We cannot now start like sieving who has a child, who does not have a child. And so we start treating those with children differently from those who are alone, because this is a pool. So that's why we cannot discriminate based on the family structure or something and give some people preferential treatment over others because they are alone. It's a pool, and this is not a money. Actually, this is not like money that is somewhere in an account. It is actually a pool. And Dr. Penny, you understand this. So when we say I have a cover of 1 million, it is not like that money is in my account somewhere. It is a pool. And it is based on the fact that some people who have that cover may use, others may not use. So that's how the insurance tenets work. So that's why we cannot treat people based on their structure of the family. The terms and conditions of the insurance have to apply equitably and equally to everyone. Thank you.
Yes, actually that question on limits and covers keeps coming up every time we do sensitization, and it's very important to know that insurance works based on pooling of resources. So the last question is to do with are dermatology preparations covered? Are supplements also covered?
I'll start with the last one. Supplements we don't cover unless they are part of treatment, like if for oncology patients, because they are required to boost or to enhance the action of chemo. But supplements are exclusion in this contract. Then dermatological products, if they are prescribed by a dermatologist to treat a dermatological issue, yes, we cover for those, but they must be prescribed by a qualified dermatologist for a dermatological condition. Of course, not like light, skin lightening products or something like that. We understand people can have very bad acne. People can have other issues that need topical dermatological products. And if they are prescribed for management of that eczema, sometimes you may have eczema. Sometimes patients may also have like a child could be having chicken pox and they require calamine lotion or something like that. Those, yes, would be covered, but they must be medically necessary for them to be covered. So if prescribed by a qualified dermatologist to treat a dermatological issue, we shall consider them. Thank you.
Great. I think the last one was just a comment, and it had to do with improving communication on the benefits package so that the members are enlightened. When they are seeking services, they already know what to expect and where to seek those services. Someone mentioned about the annual medical cover, that this information that has been shared now is good, because then you don't appear at a facility asking for the annual medical checkup just to be told that it's a pre-authorized service. So improvement of communication, and that's why it's imperative that we do this sensitizations often. This information is also available on the NHIF website. There were also handbooks that had been printed. I don't know whether there are any more available. And we are also planning for physical meetings to sensitize all NMS staff, not just doctors. So please be on the lookout for that. And those are forums where you can ask even more questions, because this, of course, has limited time. I don't know whether there's anything else.
Thank you,
Dr.
thank
Mula?
you. Yes, thank you, Dr. Penny. I noticed there was a question by Lillian from HR, and her hand was also raised at some point. I think we should give her a chance, and probably her question was directed to the NHIF team. Karibu, Lillian.
Thank you very much, Daktari. Thank you for this presentation also from the NHIF team. And as we sit in the HR, we bear a lot of the issues that come from employees, especially towards the end of the month. You know, when the remittance has not been done, employees' status is maybe indicating that we are in arrears. But when we check with the accounts department, we're informed that remittance has been done, but the status is still reading that we are in arrears. So the employees are always up and down trying to get services. So we request the NHIF team to assist. Like, let's say the month of June, the remittance was done on 8th July, but by the 12th of July, still employees were not able to get services. Another issue that we have raised is concerning the new employees. We had new employees last year and this year, and when we submitted the list to the NHIF, still their status was indicating they are on self-employed basis. They were not able to get the services. Anne has been able to always ready to assist, but you know, it takes a lot of time. Service delivery is affected when employees have to come from all the way to Ruai, from Ruai to maybe their areas of work, being referred to the NHIF office team to assist in those areas. Thank you very much.
Dr. Penny,
yes.
I saw some about whether fertility treatment includes IVF. Yes, it includes IVF, but there are rules to IVF that will also be shared, including age limit and who is entitled to IVF. And that is person who is primary infertility for a couple. We don't do IVF for single person because we do IVF as a medical treatment, not as a reproductive, you know, to help to assist just birth of a child for someone who does not want to be in a marriage. So there is that one of have to be in a marriage. The age limit for the female spouse or member is 41 years. And again for primary, but in inbred families, where apparently, like you get married with your own child, and then that marriage has not produced an issue, then we consider that. But that we also require like demonstration through the birth certificate to show that the baby that is already declared does not belong to the to both, belongs to one of the parent in the relationship. So it is covered. I've also seen someone else say we consider maternity at 500,000. Dr. Penny, that one we will have really to negotiate with the team at the Harambee House, because I'm certain that will take the premium to 12 billion. I hope Treasury would be willing to give 12 billion to cover the civil servants, but every dream is valid. We shall represent that to the committee that negotiates. But 500 for maternity would then mean if your cover is 700, you're only left with 200 for other medical issues. So, but we have taken this in notice, and we are going to be giving feedback to the standing committee that negotiates the cover. Thank you. I've also seen somebody who asked about the prescription of soaps, oiritam and other soaps by a pediatrician for children with eczema. We need to be cautious about that because of, again, that's why we were asking for dermatologists to cover, to prescribe that as a skin issue. It would be good if the prescription came from a dermatologist. Not that we are saying a pediatrician is not competent to diagnose a skin issue or eczema, but it is important that just the way we go for our spectacles to an ophthalmologist or optometrist, we also look for skin issues from a dermatologist, so that we are sure that the prescriptions are coming from the correct specialist, not undermining that even a pediatrician is able to diagnose all those things. So kindly, we've taken note of that question, but we request that even when your baby has a skin condition, I think most of us would want to also see a dermatologist for that, for a more enhanced opinion. And if they think that we need to use the oilitum and other skin, we need to deal with that eczema or that skin condition, then NHIF shall be honored to help with that, as long as the prescription comes from the right specialist. Thank you.
Thank you, Otele. I've seen a comment from Dr. Dede on the issues being brought up, the suggestions, and there's actually an exercise towards the end of the financial year that looks at monitoring and evaluation. And these suggestions are actually put down as a report and deliberated on during the negotiations. So that's also another forum in which we can bring up these suggestions.
Dr. Penny,
yes.
Allow me to just make one last comment. In terms of membership in terms of contribution, the statutory contributions, there is a deadline for paying the contributions for the current month, which is the 9th of the following month. Now, the process of making payments is fully automated. It's been automated for a long time, from around 2010 there, it's been a while. Now, when there are delays in payment by the employer, the statutory contributions, then you may face the challenges that Lillian was talking about. And this is something that we are trying to handle with the employer so that you don't inconvenience the member. However, situations where the employer has paid and the money is not reflecting in the member's account, That's something that needs to be addressed, because then there's a disconnect somewhere. The payment is done at the bank. The loading of the list of names is done through the NHIF website. So when the employer makes the payment, it automatically links to the ID numbers that are in the list that was uploaded into the website. So maybe we can address that with Lillian or the team that makes the payment or uploads the list, which is called the payroll byproduct. Because if the payment has been done and the names have been uploaded, then that situation should never occur. It should be instant.
Thank you for clarifying that, Anne. And before we close, there's a question from one of our senior colleagues, Dr. Kareri. Kindly unmute and ask your question.
Thank you for the good information you have passed to us. But my question is, between after working as a civil servant, one retires. Have you negotiated a package for retirees? And in that package, can they be treated abroad? And thirdly, can their monthly contribution be deducted from the pension? Thank you.
Okay.
Hello.
Yes. Yeah. All right. So allow me to answer this one. We've been in discussions from 2016 with the government, with the representation from the Ministry of Public Service, the National Treasury, the IRA, and the union, the members' unions, on how to have what is called a post-retirement medical scheme. Now, these discussions have gone on back and forth, and in the last financial year, there's been some good progress, because then the Ministry of Public Service, which is really the owner of the policy, informed us and confirmed to the team that there was a cabinet paper memo that had been done so that the policy can be adapted. If that is done successfully, then it means for every civil servant, you'll be able to be deducted depending on your age, or pay a lump sum if you're above a certain age, and continue being covered, enjoying a benefit like what you have now under the civil servant scheme. But then I'm sure once that policy has been adapted and the guidelines are done, then you'll be informed as civil servants and public servants. Even us as NHIF will benefit from that policy actually. However, there are some civil servants who retired earlier, public servants, went ahead of the government, formed what you call the Kenya Association for Retired Officers, and came to NHIF to negotiate for a comprehensive medical scheme. Now we've been negotiating every year and signing a contract with this association. So every public servant, anybody who served as a public servant or a civil servant, is actually free to join the association. And once you join as a member of the Kenya Association for Retired Officers, then you're able to procure or purchase a cover through the contract that we have with the association. And the cover is just as good as this one. They are actually, the benefit is almost exactly the same, except for things like maternity. And also we don't cover children in that cover unless they're disabled and wholly dependent of the parent. Otherwise, in terms of the medical, the benefit package, it's the same as what you have here. You can also go overseas under that cover. So that's what is currently active. But in terms of official policy, we've been informed that it's at an advanced stage, and we are hoping that hopefully during this financial year, it can actually be adapted and you can start being deducted as public and civil servants so that you can benefit from your pension. It's deducted from your pension and paid to NHIF for your enhanced cover.
Dr. Kareri, I hope you've gotten answered.
Yeah, well answered. Thank you.
Most welcome. Last but not least, and we need to close up, does the civil servant scheme cover COVID treatment?
Yes, it does, but I think, Dr. Penny, we need to have another meeting with the doctors to talk about the WIBA, GPA, and group life cover for them, so that they also understand that apart from the medical cover, there is the group life GPA and WIBA cover, so that we can also maybe extrapolate on the linkages between the two covers that the members have. But for now, the civil servants are covered for COVID-19. Yes. Thank you.
Thank you, Otele. Just a clarification that NMS is still not party to the WIBA and group life.
Okay.
Treasure, yes. So hopefully Treasury will accept our request. Our request had been put in the last financial year, but it was declined. So we are hoping that this financial year, our request will be accepted. Dr. Mula. Dr. Dede, before I invite Dr. Mula, do you want to say anything, any comment? Then any comment from the NHIF team to close up, then we hand over to Dr. Mula.
Thanks, Dr. Penny. Mine will just be brief. Just thank you and thank the NHIF team and the doctors for availing themselves. Yes, and like someone says, we hope that there can be more of these sessions. Just that, and thank you.
Lillian, any closing remarks from HR?
Thank you very much. The NHIF cover for civil servants has been well received, even by those employees who are under the AAR scheme. And we hope that when we get to do the sensitization, the NMS, they'll be able to understand these issues. Otherwise, I'm glad, but at least I'm seeing the number is less. It seems all the doctors did not join the meeting. So maybe we'll need to have another session to cover more doctors. Thank you.
Thank you, Lillian. We know that all of us are not able to attend, but those of us who've attended, let's kindly be champions, spread this information. As we said before, the information is also available on the NHIF website. We are here to answer any queries as well. Yes, and thank you so much for availing yourselves, and thank you to the NHIF team for a job well done. Anne, Otele, Makali, any closing comments?
I think for me, I just want to appreciate all of you for attending. I also appreciate the NMS. We've had a good relationship in the last 1 year that you've been part of this cover. And it's been a cordial relationship, and we've been able to work well together. With Dr. Penny and the other representatives, we will make sure we do a comprehensive sensitization of their staff, because I know there's a bulk of the staff under NMS are not aware of the benefits. Otherwise, we are grateful. Have a good evening.
Mine is to request that all members update their mobile numbers with NHIF so as to be able to monitor their scheme utilizations. Thank you.
Otele.
Thank you all. Thank you for the meeting. I'm hoping after this, my work will be much easier. And as I call all of us also, like if it's for COVID, we are covered, but we also use the government designated COVID treatment centers. It is easier, again, also to help with the employer with the premiums that they have to pay. Thank you so much all for this. And it was a good meeting, and I appreciate for being part of this. Thank you.
Dr. Mula, over to you.
Thank you, Penny. I just saw my chairman inside. I don't know if you'd like to say Dr. Maero, would you say something just shortly before I give a vote of thanks and close with a prayer? Dr. Maero?
No, Mula, I have nothing much to say, but just to appreciate the whole team for the good work. And yeah, we'll organize more of these meetings. It's very important. Thank you.
So thank you. I would just like to give a simple vote of thanks, first and foremost to Dr. Penny, and maybe just reinforce that currently Dr. Penny is working alongside Dr. Dede as our representatives to the NHIF team. So I hope Dr. Dede will support you in answering some of the hard questions members have been asking. My second vote of thanks goes to the NHIF team. Thank you, Erastus. Thank you, Anne, and thank you, Judith. Then I would also like to thank the HR representative, Lillian. Thank you for being here. Thank you for sacrificing your time. And the entire membership that joined us this evening. Thank you for listening, and hopefully we'll engage more. So I see Dr. Penny has shared her contact in the chat box. Those who do not yet have it can pick it from there. So I want to take this chance to just say a short prayer as we close. So let's believe and pray. Father Lord, we thank you this evening. We thank you for the productive deliberations we've had. We thank you for the information we've taken. We ask that we may be able to share it and even understand it further, and that above all, even as we seek treatment, our health is in your hands, Father Lord. It's in Jesus' name I pray and believe. Amen. Thank you to everyone and have a good night.
Amen.
Thank you. Good night.
Thank you. I've shared both our numbers, Dr. Dede and mine. So please feel free to get in touch with any one of us in case of any issues.
Thank you. Thank you. Dr. Dede works at Mawalusi.
Yes, she does.
Okay.
Yes, I do.
Thank you, Doctor.
Also, for those who had us the presentation, I've also shared it in the chat. You can always refer from the chat. Thank you.
Erastus, I can't see it. Eh?
You can't see it?
You know.
I'll share again.
You'll share again, kindly.
Yeah.
Makali, the PowerPoint presentation you shared was for National Police.
Sorry about that.
Dr. Penny, can we get the presentation later from you?
Yes, I can share it.
Okay.
Yeah, I'll share it on the WhatsApp group.
Okay.
Yeah.
Thank you.
Thanks. Good night, everyone.